Thank you very much, Paul. Paul has, in fact, set up the really the next four speakers brilliantly by touching on so many salient topics, and I'm going to be taking up the running now in terms of removable prosthodontics, and I'm going to be talking about 5 topics which sound basic but are integral to understanding things: classification of RPDs, RPD design, and then retention, support and stability. And sometimes retention, support and stability get rolled into one, but I think it's prudent to be able to differentiate between them. Okay. So, Edward Kennedy, classification. If I said to you, do you know the classification upside down, inside out, back to front? Would the answer be yes? It's something that we have to know upside down, inside out, and back to front, because it helps us discuss and it also helps us to design. Class 1, bilateral distal extensions. Class 2, unilateral distal extension. Class 3, bounded saddle. Class 4, the only edentulous space is the anterior one. That's one that people commonly get muddled up. They'll say, oh, it's a Kennedy 4 modification something. It can't be, because it's the only edentulous space. The rules, after all the extractions are done: third molars, rule 3, third molars not considered unless present. So if they're there, it's part of the classification. And then modifications. And then, like I said, knowing where does class 4 fit into the whole equation. 1 and 2 take precedence over it, and 3 takes precedence over it. So, Kennedy 1, bilateral distal extension. Kennedy 2, unilateral distal extension. The 7 isn't being replaced, so therefore it's a Kennedy 2. Kennedy 3, or Kennedy 2 modification. You do it from the Kennedy 2. The Kennedy 2 is the guide, is the overarching one. So here you might be tempted, is that a Kennedy 3? No, it's a Kennedy 2 mod 1. Here, this is a Kennedy 2 mod 1. Those two examples are the same classification, even though they look completely different. But if you apply the rule, it'll make sense. Kennedy 3, bounded saddle. Commonly, the major connector in a Kennedy 3 will be a palatal strap. This is an open ring that you see here, but commonly it'll be a palatal strap, particularly if there's a modification. They're an example of palatal straps. Palatal straps should be 12 to 15 millimeters wide. The one on the left is only about 7 millimeters wide. Kennedy 4, just the anterior space. Don't get tricked into thinking this is a Kennedy 2 mod 1. Okay? So, in your mind, just see, do you know what the answer is? So that would be a Kennedy 4. That would be a Kennedy 3 mod 1. That would be a Kennedy 3. This guy up here, Kennedy 1, Kennedy 2 mod 1. This guy here, Kennedy 2 mod 1. This guy here, Kennedy 2 mod 2. You all know that. Okay, well done. So second, RPD design. What do we need to design a partial denture? By the way, who should design the partial denture? The dentist should design the partial denture, because only the dentist can do the clinical examination. The laboratory have an inanimate cast. Only the dentist know if that tooth moves. The tooth never moves on the cast. So we have to do the clinical examination. Study casts and the surveyor. What is a surveyor? It's a paralleling device. This is what it facilitates us to do. We can't design a partial denture without a surveyor. Gives us the path of insertion, retentive undercut, soft tissue undercut that maybe we have to utilize in our path of insertion. It helps us get rid of dead spaces, black triangles, and then it brings all those aspects together. So what are the steps in an RPD design? These are the steps. path of insertion, which utilises the guide planes, major connector, support, retention, and then when you've done that, is there anything you can eliminate to streamline your design? So, path of insertion, guide planes. This is what we want. We want that there is no space between the distal of the tooth and where the RPD will go in, the mesial of the tooth and where the RPD will go in. If there's a big undercut in there, you might consider doing a tooth preparation. Maxillary major connectors, these are the 5 types. Okay? This is what they look like. Full palatal coverage. You do that when you have very few teeth left or when you're going to be losing some more teeth. AP ring, very common design when you might have something like a Kennedy 4 and you want minimal coverage of your palate. This is called a swing lock. Swing lock is utilized when you have just anterior teeth that are very proclined and you won't be able to get clasps on them. You have a little gate that closes around the labial of them. Palatal strap, like I said, 12 to 15 millimeters in width. Horseshoe. Horseshoe is a very commonly used major connector. It should only ever be used if you have distal abutments. If you don't have distal abutments, if you say had a Kennedy 1 or a Kennedy 2, never use a horseshoe. It will extract the distal abutments. When would you say this is most commonly used in practice? It's most commonly used in Kennedy 1s and Kennedy 2s, the very time it shouldn't be used. So horseshoe major connectors, Kennedy 3s. Or you could consider in a Kennedy 4. These are the lower major connectors. So we've already got our path of insertion. Now we're trying to connect everything. Lingual bar, sublingual bar, lingual plate, split plate, labial bar, swing lock. How much space do you need for a lingual bar on the lingual of the lower anterior teeth? You need 8 millimeters. 3 millimeters of space from the bar to the floor of the mouth, 4 millimeters of space for the bar, and 1 millimeter space to the gingival margin. If you don't have that, you cannot use a lingual bar. It will produce repeated ulceration. In that situation, you would use a lingual plate. So we have a lingual bar here. How many millimeters do we need for that? 8 millimeters. If we don't have it, we would consider lingual plate. Or in a Kennedy 1 or a Kennedy 2, we might consider a lingual plate for indirect retention. Split lingual plate. Areas where you have diastema between teeth. History of perio, you want minimal coverage. Labial bar. When would you use a labial bar? You'd use a labial bar if the lower anteriors are very retroclined and you're not able to get your major connector in. So we spoke about a swing lock in the upper when they're proclined. We talk about a labial bar when they're retroclined in the lower. Support, rest seats. Very, very important. In Kennedy 3s, the rest seat are put adjacent to the edentulous space. In Kennedy 2s or Kennedy 1s, the rest seat is put mesially. If it's put distally, it will help to extract the tooth. Distal extensions, the rest seat is put mesially. It directs load onto the abutment tooth, it resists movement of the prosthesis downwards, horizontal stability, and I think the one that people forget all the time, it maintains the retentive component in the proper position. If the denture isn't supported vertically, your clip is going up and down. So very important. What should the dimensions of the rest be? The rule of thirds and fifths. 1/3 of the intercuspal width, 1/5 of the mesiodistal length. And the same if you're doing inlays or anything into your restorations, the same dimensions, into your abutments, the same dimensions occur. There are 2 types of retention, direct retention and indirect retention. Direct retention is offered by retainers. There are 2 types primarily, occlusally approaching and gingivally approaching. Which offers more retention, an occlusally approaching clasp or a gingivally approaching clasp? A gingivally approaching clasp. And the way you remember that is if you were pushing a wheelbarrow up onto a footpath, would it be more difficult to push it up or pull it up? Gingivally approaching pushes. It's more difficult to push a wheelbarrow onto a footpath. There is more resistance and retention. So gingivally approaching clasps have more retentive capacity. Indirect retention, anterior to the fulcrum line on a partial denture, say in a Kennedy 1 or 2, everything that is anterior to that at a right angle offers indirect retention. So resistance to displacement away from the tissues. That's indirect retention when the saddle comes up. We must have the correct undercut. There are different amounts of undercut for different types of clasp. A cast clasp, 0.25 millimeters, wrought clasp, 0.5, and wrought gold, 0.75. That's important to analyze. How would you know what undercut you have? Through the use of your surveyor. Distal extension partial dentures. Special category of partial dentures. You've got that from what I've been describing. So what's the most favourable clasp design in mandibular Kennedy 1 partial dentures? What's the most favourable clasp design? 3 letters. RPI. Great. So the RPI concept. So what does it allow us to do? What is it? R stands for mesial rest. It directs the axis, the loads down the long axis. Proximal plate. The proximal plate should be slightly lingual, and just the head of the plate should be just at the height of contour, so that as the person bites and this goes down, the denture can move in this direction. The clasp, which is on the mid-facial, as the denture goes down here, the clasp goes down and forward. It is disengaging from the tooth. You never put an eye-bar on the distal of the tooth in a distal extension partial denture. Never. It's always mid-facial or mesial. So the advantages of the RPI, the proximal plate and the eye-bar move away from the tooth, like I was describing there. The mesial minor connector and proximal plate eliminate reciprocation needs. Eye-bar is more aesthetic. Minimal contact. Caries-prone individuals, the eye-bar is better than an occlusally approaching, and it eliminates the class 1 lever. Retention, support, and stability for complete dentures. Retention. Resistance to displacement away from the tissues in a vertical direction. There are 3 methods: physical forces, muscular forces, and mechanical retention. We forget about these. We think of suction when we talk about retention, but it is made up of all these aspects. So, principles for physical forces: maximum surface area, close adaptation, and peripheral seal. So, adhesion is a physical force, cohesion is a physical force, interfacial surface tension is a physical force, capillary attraction is a physical force, and atmospheric pressure is a physical force. So, adhesion, unlike molecules, the saliva to the mucosa, the saliva to the denture. What's critical for this? We must have maximum surface area. Cohesion, physical attraction of like molecules, so within the saliva. What's essential for this? We need thin saliva. Thick, ropey saliva, disadvantage. What's the key? The key is surface area covered. You must have maximal surface area for good retention. Capillary attraction, like in the capillary tube and the meniscus and all that business, force is directly proportional to the area covered. So you're getting the message, area covered. And atmospheric pressure, this is like the get out of jail one. It just gives you that extra bit of holding the denture in place. And what's it directly proportional to? Surface area covered. Okay. The muscles. We need the denture to work with the muscles. So things that challenge good retention. If the border of the denture isn't in good harmony with the muscles, if it's overextended or underextended. Friendly contours. This area in here, we're talking about a lower, so it's not strictly retention, it's more stability, but Same concept. If we don't have a nice contour there, the tongue will want to lift the denture. So harmony with muscle forces. So poorly contoured dentures reduce retention, stability, support. Mechanical retention, very important to look at an edentulous cast. Just like you look at undercuts on a dentate cast, look at an edentulous one. So if we take this case, for example, this patient, huge big maxilla, right? You would think it should be easy to make a denture for that person. This was the denture that had been made for them. The denture has minimal extensions, so we know it's not going to have maximal surface area. We have a lot of papillary hyperplasia, denture stomatitis, and it's because the dentist wasn't able to get the denture to go home. The undercuts were too big. So the solution, you can do surgery, or you can use a path of insertion where you might come in from one side with the denture, in like that to that undercut, and then rotate up. So use of undercuts can really help. Paul spoke about disease in diagnosis. Probably the 3 or 4 you would need to know in terms of removable prosthodontics, inflammatory papillary hyperplasia, denture stomatitis, angular cheilitis, and denture granuloma. Those would be 4 common things that you would notice. Oh, sorry, there's a 5th one. Yeah, those would be the common things that you would be asked about soft tissue lesions in complete dentures. How do you test for retention, support, and stability? This is how you test for retention. Pull on the canines. If it doesn't come down, you have retention. Doesn't mean anything other than that. Tip at the front, that's the post-stam. So what do you think of the extension of this denture yourself? Well, when we look at the tissues here, that's the outline of the denture. That's the fovea palatini there, so this denture is underextended. Will it have maximum retention? No. Is surface area a big deal for dentures? Huge. Okay. This person says my denture is moving. What do you think of the extensions of it? It's probably underextended here. Okay. So we put a little bit of green stick on to do a test. It improves the retention. We convert the green stick into acrylic and the denture is improved. Why was it improved? Because we improved the surface area. Okay. This is a famous Gaelic footballer coach in Croke Park cheering his team on, and his denture was displaced. Why did that happen? Because if you look very carefully, you can see it's a bit underextended, just there. Okay. So support, resistance to displacement in a vertical direction. It has to do with 2 things. It has to do with the adaptation of the denture and the condition of the tissues underneath. How do you test for it? You push on the first premolar. If the denture rocks, there's poor support. If the denture is solid, there's good support. If the tissues underneath are mobile, it may move, but it won't rock. It'll stay with the tissues. So the flabby ridge. So you can see me pretending I have some video on my footage there, and that's that ridge moving. So if you see that, you have to compensate for that by perhaps changing your impression technique. A mucodisplacive technique, such as using alginate, will scrunch up that tissue. It will produce sores. It will accelerate resorption. It will cause disharmonies. So you want a mucostatic impression material, particularly in the area of where the flabbiness is. Final thing, stability. There are 3 things that control stability: the borders, the occlusion, and the tooth position. Okay? So, how do you test for stability? You know how to test for retention, you know how to test for support. How do you test for stability? You go up to the buccal sulcus, you pull out the denture, and you pull out the buccal tissues, and if it doesn't knock the denture down, then you have good border stability. I spoke about 3 things: borders, occlusion, and tooth position. You do the same, and on this one you pull it out, and this frenal attachment is knocking the denture down. So this denture is overextended in that area. So if a person comes in and says, my denture is loose, and you say, no problem, I will reline your denture, but if the denture is already overextended, will you improve the situation or will you make it worse? Okay, so you have to decide, is it retention, is it support, or is it stability? That's the issue. Again, friendly contours. I repeat that. Eamon Croke, a dentist here in Dublin, is superb at contouring his dentures, and it's like as if they were just grown in the person's mouth, and he's always talking about this context. Occlusion. So this lady is wearing an upper denture and a lower partial denture, and she describes that her upper denture is loose. Now, it could be loose for a lot of reasons, but what one reason do you think it might be loose? When I bite my teeth together, my top denture is loose. What might it be? It might be that the canine here is knocking off the top tooth, the denture, right? So it's an occlusal problem. And you ask the lady to tap together, and the denture moves, and the denture moves. You test for retention, it doesn't come down. You test for support, it doesn't rock. So what are you going to do? Well, you might level the canine, but if the vertical dimension is correct, you might add some acrylic instead on either side. Obviously, you can make new dentures, which would be the optimal, but you can add acrylic, and now that top denture doesn't move. So you've done a diagnostic test to work out the problem. Opposing natural teeth against a denture, very difficult to make the upper denture stable. What might this cause? There's a condition, something syndrome, combination syndrome. What are the 5 things in combination syndrome? Anterior flabby ridge, papillary hyperplasia, pendulous tuberosities, roller coaster, lower occlusal plane, and resorbed posterior mandibular ridges. Okay? Look it up. Okay. So if you have lower anterior teeth, consider making a partial denture at the lower back teeth to reduce that rocking and rolling. How do we control occlusion? Well, we can do remounts, we can do equilibrations, and the time you might correct the occlusal problem is at the try-in, after you process the denture in the laboratory, at delivery of the denture, and if the person comes back and they have soreness on the ridges, not in the sulci, but on the ridges, it's very commonly an occlusal problem. So consider doing an equilibration. So what's the rule for equilibration? Where do I adjust? The red dot or the blue dot? It doesn't matter what color the dot is, it matters where the dot is. So in centric, Paul spoke about centric and MIP and that. In centric in dentures, going straight up and down, you adjust the fossa, only the fossa. You've heard of the bull rule, you've heard of the Lubbock rule. Bull rule, buccal upper, lingual lower. When you're doing eccentric, working side, you use the bull rule. You equilibrate the buccal of the upper and the lingual of the lower. And if it's on a non-working side discrepancy, you use the Lubbock rule, lingual upper, buccal lower. Many times students, when I would say, where do you adjust on a denture, they'll say the bull rule. That's only working side. So always start from centric, adjust the fossa. 3 contacts on each side if possible. So what are the controllable things in terms of stability? Well, we know we can control extensions by good impressions. We don't want overextension. We don't want underextension. We can control occlusion by equilibration and careful jaw relations. Tooth position, where we put the teeth. If they're in the wrong place, the muscles will lift them up. And we can control fit. Fit important in terms of close adaptation, retention, etc. Tooth position, so where should they be? If they're too far labial, the mentalis will lift them up, the orbicularis will knock them down, etc. So let's get them right. What are the guidelines? These are the guidelines. The upper front teeth should be 10 millimeters in front of the incisal papilla. If they're too far out, they'll get knocked down. If they're too far in, the person will look collapsed. Where should the lower anterior teeth be? The necks should be coming out of the sulcus out of the sulcus. If the necks of the lower teeth are too far forward, we're going to have a situation where the denture is getting displaced. So we want the necks of the teeth coming out of the sulcus. This is the most common denture setup problem that we see all across the board. So in this situation, the teeth are out here, the sulcus is back here. What do you think might happen to this denture? It might lift up every time they smile with mentalis. So that's where the sulcus is. This is where the necks of the teeth are, out too far. This person, their lower denture jumps up when they're talking. What do you think might be causing that? Overextension? No, lingually it could be, but I would say in this situation when they're moving their lips like that, just labially. But it can be legally, and you would test by having the tongue move to the left, and if it lifts up on the right, it's overextended on the right. And you move the tongue to the right, and if it lifts up on the left, it's overextended on the left. So you don't want a situation when a person comes into your surgery who you've made the denture for, and they say, hi, and then the denture drops down. So in this situation, the upper front teeth were out too far and are getting dropped down by the lip. Back teeth should be in Pound's triangle. This is Pound's triangle, from the base of the retromolar pad to the canine. If the teeth are in that triangle, the tongue and the modiolus and the buccinator are happy. Keep the teeth in the triangle. Keep the teeth over the ridge. Halfway up the retromolar pad, that's where the occlusal plane should be. Why is that? Because that's where your teeth are in your mouth. If you put your tongue from the back of your 6 and 7, you're halfway up the retromolar pad. If we get above that, we cause instability. We should be level with the lateral border of the tongue. Halfway up the retromolar pad, that's where the teeth should be going. 6, 7, halfway up the retromolar pad. So we've two more slides. What do you think of this? This is the retromolar pad here. What do you think of the occlusal plane here? Too high or too low or perfect? Too high, yeah, causes instability of the denture. That's where it should be. How far back should the teeth end? My lecture should end now. So how far back should the teeth be? Should the teeth be back here? Should the teeth be here? Well, the teeth should end where the slope starts going up. By having a tooth above the retromolar slope, when the patient bites, it's like a ski slope. The denture is getting shifted down that slope. So keep the teeth just above the flat part of the ridge. And in doing that, you will contribute and continue to have good retention, support and stability. Thank you very much. Our next speaker is Dr. Jerry Cleary. And Jerry is a prosthodontist.